welcome everyone to the latest installment of EMS Focus, a collaborative federal webinar series. My name is Noah Smith. I'm a project manager with the Office of EMS here at NHTSA, the National Highway Traffic Safety Administration. And together with our federal partners, our Office of EMS is focused on advancing a national vision for EMS, which provides the best care across the country to our communities. The projects we undertake and the resulting resources for the community help managers plan for system improvements, measure the health of EMS systems nationwide, and we deliver the data that EMS leaders need to advance their individual systems. Another role of our office is to educate the community on new innovations and processes and technologies that can, in the end, help provide better and more efficient patient care. And so this free webinar series is a unique opportunity for federal EMS agencies to share information with our stakeholders in a manner that's a bit more personal and less time-consuming than attending conferences, but offers the opportunity for the community to interact with us and ask questions that a newsletter or an article obviously just can't provide. So just a reminder to folks that today's webinar is being recorded. We'll be archiving this webinar at www.ems.gov for future viewing and listening. More information on the EMS Focus webinar series is available on ems.gov. You can find recordings of all of our previous webinars from the last several years. Head to ems.gov, click on News and Events, and then EMS Focus. Next slide, please. So today, the NHTSA Office of EMS is pleased to partner with our friends at the Office of the National Coordinator for Health Information Technology, or ONC, at the U.S. Department of Health and Human Services. We're going to discuss a new funding opportunity to build connections between EMS data and healthcare partners. And improving EMS systems, right, and the quality of patient care that the emergency care system delivers is our top priority at NHTSA and our Office of EMS. And of course, it's a passion of mine. I might be speaking as a representative of a federal agency, but I've been an EMT for over a decade. I continue to volunteer for a local fire department just outside of Washington, D.C. So this is personal for me as well, and a really exciting opportunity to share with each of you. Next slide, please. Today, we're going to talk about how EMS can be a true partner in health information exchange, both offering and receiving information to improve care live on the scene with the patient, but also later on when reviewing cases and learning about outcomes and improving systems of care. We'll talk about the HITECH Act and what that is, and the implications of a CMS letter that was published earlier this year, and how to leverage funding that may be available to you through your state Medicaid office. It's important to note, as our friends at ONC will remind us, that what we're offering today is information, and for the purposes of information sharing, we're not offering any official guidance for grantees or anyone who may be applying for money through CMS or ONC. We'll be discussing some possible activities that could be funded under this incredible 90-10 matching program. And so with that, we encourage all of you as attendees to submit questions during any point of the discussion. We'll get to them at the Q&A session at the end of the hour together. And any questions that we don't have time to answer, we'll compile into a document and hopefully get answers posted onto ems.gov afterwards. Next slide, please. Today, we're going to spend the bulk of our time hearing from Tom Novak. He's the Medicaid Interoperability Lead at ONC. Tom is leading the effort to expand funding opportunities from the HITECH Act to new partners like emergency medical services. We'll also hear from one of my favorite people, Rachel Abbey, also from ONC, who's become the EMS expert and EMS advocate within ONC. Her partnership has led to a number of excellent projects and documents that we'll discuss today a little bit later on. And if anyone worries that nobody in federal health IT understands EMS, I can assure you that Rachel and her colleagues do. It was some of the previous work done by Rachel that helped EMS be included in this latest funding decision. So we offer an incredible amount of thanks and gratitude to her and her colleagues at ONC. My name again is Noah Smith, and I'll serve as the moderator for the Q&A session. And I'll also open our discussion with a little bit of background and a little bit of what we do here at the NHTSA Office of EMS. Next slide, please. So this is a cartoon that we've used before to illustrate some of the challenges that our industry faces with healthcare data. It's a picture of a nurse in a doctor's office with a patient. She says the doctor will be in shortly to type on a computer and update your chart. If he has time, he'll ask you how you're feeling and take a look at your rash. And sometimes this feels like the state of healthcare data in our country. And I think this is especially true for EMS, where a lot of folks don't see the value in the information that we collect on every patient every day, right? It isn't this incredible tool necessarily to offer safer, more efficient, more evidence-based care, but it's a hindrance, it's an obstacle to perhaps a patient-doctor relationship or to an EMS provider-patient relationship that we don't always see the value in. And what we know, though, and what our partners in the healthcare system are beginning to learn, is that the charts that EMTs and paramedics fill out is not just how you get paid, it's not just how you defend your agency in court, it's not just how you find trends and report on compliance and identify areas for clinical improvement. Really, it's the key to improving the emergency care system. And in many places, the missing link for policy change at a state and a local level. And data, I think, anyway, is our ticket to integration into the healthcare system. And today's conversation is about a new opportunity to get us there. Next slide, please. The great news is that we have a solid starting point, which many other parts of the healthcare system do not have. Over the last decade, state, local, and national leaders have implemented a true point-of-care data collection standard. And whether you love it or hate it, or don't understand it, or somewhere in between, it puts us in an incredible position to integrate our data with other health system data. It's called NEMSIS, or the National EMS Information System, and I'm fortunate to serve as its project manager here at NHTSA. Next slide. This is not something, though, that we at NHTSA can do or want to do alone. The Federal Interagency Committee on EMS, or FICOMS, because everything gets an acronym, is a statutorily authorized committee of 10 federal agencies who coordinate EMS activities, and they've recognized the importance of standard data and of NEMSIS as well. They said in August of last year that standardized and accessible patient-level data is essential to the improvement of pre-hospital emergency care and the integration of EMS into the broader healthcare system. And they go on to encourage federal grant dollars be used to implement NEMSIS version 3 compliant systems. Next slide. And our friends at ONC have recognized this publicly as well. This is the cover of the Federal Health IT Strategic Plan published in 2015. Next slide, please. And in it, ONC discusses the importance of EMS data, not just for pre-hospital care, but for long-term care and improvement as well. And I apologize for all the text on this slide, but I think one of the really key parts of this text, which is from the Federal Health IT Strategic Plan, is right at the bottom, where ONC recognizes that access to linked outcomes data from hospitals can help EMS systems measure performance, improve the provision of care, and provide timely feedback back to providers, something that we've been advocating for and asking for decades. Next slide. And ONC followed up that report with what I think is a great publication reviewing 3 use cases for EMS and health information exchange. And they include the first one on day-to-day operations, which in this use case is about improving immediate treatment of EMS patients and their continued care in emergency departments. The second use case was on mobile integrated healthcare and community paramedicine to improve care coordination and population health and increase appropriate utilization of not only emergency but urgent and time-sensitive care services as well. And the third one is on emergency preparedness and the need for better access to health information during a disaster or to support evacuation and long-term movement of patients to other regions or other parts of the country. And to make all of this a reality, we need motivated folks within EMS to step up and to push for inclusion in health IT investments and integration. And we all know that nobody is going to do that for us. We're the only ones who are going to be able to step up and advocate for ourselves. And fortunately, we have a new way to get EMS to the table, along with our EPCR vendors, our state leaders, and our regional partners like health information exchanges. Next slide, please. So with that background, I'm going to hand it over to two experts in information exchange. First, Tom Novak from ONC is going to discuss new opportunities for EMS to be included in and funded to build data connections with other healthcare system partners. So I'll hand it over to Tom. Thanks for joining us.
Thanks, Noah. So as Noah said, this is a new opportunity. The most important of this is talk to your Medicaid agency, talk to your Medicaid agency, talk to your Medicaid agency, because this is all tied to being a Medicaid provider. If you are not a Medicaid provider, go out and become a Medicaid provider, because that's really crucial here. So I don't know, let's, next slide, please. I don't know how much everybody knows about the HITECH Act. So I'm going to give a quick blurb on that. The HITECH Act was part of the Recovery Act, and that included within it the HITECH Act, which incentivized doctors and hospitals to use electronic health records. If they use really good electronic health records, they received incentive payments. The program was run by Medicaid and Medicare. Medicaid's is still going. It has 5 more years. And the Medicaid HITECH Act also has administrative dollars that they give to state Medicaid agencies. These administrative dollars can support statewide health information exchange. The universe of providers who could be supported with that health information exchange was sort of narrower than Medicaid providers. It was incentive eligible Medicaid providers. So that was typically acute care hospitals and primary care clinicians. You got some random dentists and NPs in there, but generally a pretty narrow universe of providers. That smaller universe was still supported by $350 million in the last few years for health information exchange activities. And that number continues to go up. So even though it's a sort of a small group of providers, it is a good chunk of money that's gone towards them, and it continues to escalate. Next slide. However, we have been working for a few years now to expand that definition. The statute around the HITECH Act was written sort of broadly, and it said it's money that can support Medicaid providers. So we argued that, argued isn't the right word, it's more of an internal lobbying. We lobbied the Office of General Counsel, the White House, the Office of Management and Budget to let us expand that definition to include all Medicaid providers, because the nature of interoperability is that the incentive eligible providers, so the acute care hospitals, the primary care clinicians, they want to do transitions of care to beyond that universe. They want to do transitions of care with long-term care providers, behavioral health providers, substance abuse treatment providers, ambulances, hospitals, or ambulances, laboratories, public health agencies. So the smaller universe of providers was sort of defined at a time that made sense, because it was meaningful use. The program that creates the definitions around funding, the first stage of it was really just focused on adopting electronic health records. But stages 2 and 3 were focused on interoperability. So these incentive eligible providers, the primary care and acute care hospitals, wanted someone to do transitions of care with. They're throwing the ball, they wanted someone to catch the ball. And EMS providers, you are on the list of people who they wanted to throw the ball to, who could then catch the ball. And similarly, and torturing the metaphor a bit, they wanted to catch the ball from you when you threw it. Next slide, please. So, done, we were able to get that approved February 29th, Leap Day, 2016, to have a broader definition of who can be supported by those funds. We put it in the blog from Dr. Karen DeSalvo and Andy Slavitz. And Dr. Karen DeSalvo is the Assistant Secretary of Health, Andy Slavitz, the Administrator for Centers for Medicare and Medicaid Services. Next slide, please. So a few specifics on how this works, just to sort of manage expectations here. So this is a 90-10 federal match. So the state Medicaid agency still has to come up with 10%, but then they are free to use that 90% to support the health information exchange activity that may include EMS providers. It is until 2021. This guidance is in place. So it is always tied to the meaningful use objectives, which we're going to go into in a little bit. But they're basically things you would want to be able to do anyway, things like transitions of care, public health reporting, medication reconciliation, medication allergies, so that's sort of the electronic tracking of structured data points that are certainly relevant to emergency medical service providers. Next slide, please. So I guess that's the basis of it. That's the language in the statute that allows for this this kind of work. Next slide, please. So the funding is in place till 2021. It is for implementation only. And what we mean by that is if a state wants to, I'll use an example that relates to emergency medical service providers. If a state has a statewide health information exchange and they want to onboard EMS providers to it, they have to do it just for implementation purposes. So it can't be a forever thing. It can be sort of a one-time project. And it can take 18 months. Like, that's fine. Like, onboarding could be they send somebody out there to help the EMS providers establish a secure connection, sort of do the technical work, but then also look at the workflow analysis and business process modeling to do the administrative work. So it can be sort of a long implementation period because we want it done right, so we don't want to rush implementation, but it is for implementation only. It is needs to be cost allocated if it goes beyond Medicaid providers. So if you're building something that benefits non-Medicaid providers or non-Medicaid payers, you have to cost allocate it. So if you're building some statewide thing and 70% of your providers are Medicaid, Medicaid will only pay for 70% of it. So it's, I think, somewhat intuitive, but it gets to be a little complicated as you drill down, and we're always happy to help in understanding some of those technicalities. Next slide, please. So next slide. There are two buckets of work, really, that this falls, that are supported by these funds. One is architecture and one is onboarding. So I'm going to go into both. So at a high level, architecture are the things you can build that are parts of a health information exchange. So I know I keep using that term, and it may not mean much without talking about specifics. So I'm going to go into a few examples, but not an exhaustive list of what some examples are. And these are some high points of what HIE architecture might involve. And I'll go into each one of these in a little more detail, but just to sort of prep you, and then also if you have additional questions about other kinds of things that might be supported, please feel free to reach out. Next slide, please. The other piece of work is onboarding, which I mentioned a little before. So onboarding is the act of getting somebody both administratively and technically connected to a health information exchange or some other sort of interoperable system. So it's that technical steps of looking at encryption standards, getting your the system on the EMS system connected to the HIE in a way that can support meaningful use for those Medicaid providers. Looking at certificates and all the really technical sort of pieces of it. There's also the administrative work, right? And that's sometimes more difficult. The administrative work to look at contracts, look at consent models, look at what sort of legal questions are there. I mean, you need somebody to think through the business associate agreements under HIPAA or what those are. And that's oftentimes your bigger barrier to interoperability is establishing those administrative relationships and looking through those things. And you can use the Medicaid money to support both of those things. So that's great, right? So the HIE onboarding, again, is implementation only, but the states can set their own benchmarks. So if a state wants to implement an onboarding program for EMS providers, if the state says, we will consider ourselves implemented when we have onboarded 95% of EMS providers to our statewide health information exchange. EMS, we are not going to push back against that. That's fine. Like, we want aggressive implementation targets, and we want good implementation. So we don't want just an establishment of a connection. We want a connection, but we want tests. We want test data to flow, and we want production data to flow. We want to make sure everything that we want to happen is actually happening. And the most important thing is that it be sensitive to workflow. I think when you adopt electronic health records, one of the biggest complaints you get is that the clinician feels like it is now an inefficient use of their time, or the EHR was not deployed in a way that helps them. And most of the time, that's a workflow complaint. You will find just as many, if not more, clinicians who love their EHR and find that it improves their quality of care. but they don't complain. They're typically too busy taking care of patients. But it's really all about workflow considerations. So if you're going to merge your EMS systems with acute care hospital systems or health information exchanges or other health systems or regional health information organizations, you need to do that homework, that business process modeling of seeing how the workflow plays out. And CMS can support that really, really crucial workflow consideration where you think about, okay, somebody is transported, what will be the way in which we relay the information and what information to include, and will it be segmented, will it not be segmented, what's the consent model, that kind of thing. So it's very important to be careful about these things to make sure it's done in a way that is very provider friendly. Next slide, please. So I'm going to go, next slide, into some of the use cases a bit. So these are when I talk about architecture, I'm going to give some definitions of some of the kinds of architecture we have. I think a provider directory is a good example for EMS. So a provider directory, and forgive me, ONC colleagues, for oversimplifying, but a provider directory can be simply described a bit as white pages of electronic health or of provider addresses, electronic addresses. So one provider has to do a transition of care with another provider. They go into a provider directory that might be on a web portal or it might be connected to their EHR or connected to another system. So they go into a provider directory, look up the provider they want to do a transition of care with, and then they can just send that other provider structured data, secure messages, medication history, problem lists, any sort of other structured data that is able to be supported by the provider directory. And the connections can be supported, like the whole system. So the provider directory and the connections to the system can be supported with that 9010 font. That's one of the most basic kinds of health information exchange, and a lot of times it's also something, next slide please, that can be supported in conjunction with some of the other kinds of state Medicaid dollars. So as you talk to your state Medicaid agency, you should know there's more than one bucket of money. The bucket of money we're talking about now is only one bucket of money. There's another bucket of money called MMIS. That's a statewide claims payment system, but it also can support provider directories. So you might have a sort of a varied funding model, and that gets to be very technical, which is why you should consult myself or CMS if you want to help the state Medicaid agency figure out how to pay for it in a way that really helps everybody. And we work with CMS very closely. I'm actually part-time at CMS. I'm detailed 50-50 between CMS and ONC, so we can really dig into some of those ideal funding models that'll help everybody get as much bang for their buck out of these various funding mechanisms. Next slide, please. So another use case, it sort of relates to provider directory, but it's that layer underneath, which is that secure messaging. So that's just what it sounds like. You can almost describe it as secure email, the ability to send HIPAA-compliant messages back and forth between clinicians. And it doesn't need to be in a provider directory. It can happen outside provider directories, inside other systems like encounter alerting systems or standalone systems. But any other model a state is interested in pursuing that uses secure messaging, we can support that. Again, it always just needs to have some of those incentive eligible providers in the mix, which it always would. Like you wouldn't build anything that didn't have an acute care hospital or have primary care in it. So anything you're building is going to probably meet the criteria because the policy bar is pretty easy to meet for these systems. So you're going to build something that's going to connect other Medicaid providers using secure messaging pretty easily, and you can send structured data, you can send pretext emails. As long as it hits various meaningful use objectives, you're fine and you can be supported. Next slide. So some of these are a little more relevant to EMS. Encounter alerting is something I know a lot of EMS providers are either already doing, already interested in doing, or would like to learn more about. Encounter alerting is known by a few things, so let's do a little acronym decoding here. It's also called ADT, Alerting, Adult Admission, Discharge, and Transfer. It's also called ENS, Notification System. And that is, again, just kind of what it sounds like. So if you have a patient, and that patient goes from the the skilled nursing home to the ambulance to the emergency department, there's a few changes in encounters there, where they're going from one care setting to another care setting to another care setting. And it is always helpful in terms of care management and case management to make sure someone is notified of these things. So if you are moving towards these more advanced care models of medical homes or ACOs or hospital readmission programs where you're trying to really do some intensive case management, you need these encounter alerting systems. And if you talk to anybody who's out there building an ACO will always build an encounter alerting system first. It really moves the needle on cost and quality. And I think that the EMS providers are in a great position to add very helpful data to the encounter alerting world. So those systems can benefit a lot from knowing what you know. So knowing where patients are going and who's getting readmitted or who is getting discharged, and sort of being part of that electronic workflow would really be critical for some aggressive case management strategies. Next slide, please. So Care Plan Exchange kind of complements encounter alerting nicely. So Care Plan Exchange is so think of a care plan as an editable electronic plan that follows the patient. So it doesn't really live anywhere. It lives in the cloud, to be a little conceptual. So it's something that many providers can go in and edit and update, and patients are a part of the care plan. It is something that has goals in it typically. So let's think of maybe a non-compliant diabetic, for example. So a care plan might have contributing to it for a non-compliant diabetic. You might have an endocrinologist, an ophthalmologist, nephrologist. You might have hospitals who have contributed for various things, or you might have a patient who's on home care for dialysis, so they have home health needs, and they've maybe gone to the emergency department a few times. So they've maybe had emergency medical providers, taking them, to dialysis or some other sort of relationships that they have, or appointments or other needs that they've needed that all should really be tracked in one place. Maybe they have a goal around A1C, or maybe they have something in their care plan that says, if X happens, then we have to pull in their case manager, or pull in their social worker, or pull in their medical home. So the nurse who's acting as a care manager at their medical home has some sort of follow-up duties based on what happens in the care plan. So the care plan is a sort of dynamic, editable document that is electronic, that everybody can sort of contribute to, and really is good at coordinating care. And again, this is something to think about along with the encounter alerting that helps those patients with multiple chronic conditions. So if you have the super utilizers who are very expensive, very high need in terms of specialists and whatnot, care plan is very necessary. So you start to get to see the importance of coordinating care in these very difficult situations where coordination is challenging. Next slide, please. A little more on care plan. So the standards. I don't think we need to go into the standards too much. If we get into weeds, we're talking about your state Medicaid agency. This is where we'll talk about standards and how to do it. And not to say these aren't important conversations, but I just want to give a flavor for what might be on the table for everybody. Next slide, please. And next slide. Everybody gets these slides too. You're not missing anything too juicy. So HITECH services are sort of the governance entity. So connecting yourself to a health information exchange is going to be tricky. It's similar to onboarding. There's a lot of logistics involved with contracts and aligning encryption standards and looking at certificates. If you're ever surfing the internet and you occasionally go on a website that says the certificate is not valid for this website, you may not know what that means. That is actually something that is a big barrier towards healthcare interoperability. Now you know. These certificates sort of are not coordinated at the federal level, but a HISP can coordinate certificates, and so that's something that they can align. A certificate verifies that a computer is who it says it is, and So one computer to another computer has to align certificates and like ISPs and whatnot to make sure information moves. And that's kind of a gross simplification, but that's really what we're trying to do with some of the HITECH services, is to make sure the data really flows at a more local level. And they're very integral, so that we can also support that at the state Medicaid level. Next slide. Next slide again, please. Query exchange is just sort of what it sounds like. A lot of state Medicaid agencies are set up well to be query exchanges. They already are getting a lot of data. So a query exchange is just a little different than some of the other models that we're talking about. It is just what it sounds like. You ask a question to the Health Information Exchange, and it gives you an answer. So if you have somewhere in the EMS continuum of care need to ask questions, either the EMS provider is asking the questions or the EMS provider is providing the answers, but you can be integrated to that equation, and I think it could be helpful in some models. A lot of state Medicaid agencies prefer this model because they kind of have a head start based on the way their data works in Medicaid, because they're already receiving a lot of data from claims and other sort of encounter data. They can populate a query exchange, a clinical data warehouse, with a lot of the answers to the questions ahead of time. So the query exchange is kind of a short walk for some state Medicaid agencies. Next slide. So public health systems may not be obvious, but stick with me here. How EMS could also use 9010 to support their role in public health systems. So part of meaningful use is providers have to supply information to immunization registries, syndromic surveillance registries. Maybe it doesn't come up a lot with EMS providers, but we also responded to providers who said, look, you're making me supply information to immunization registries, and I'm a dentist. That's not really something I do. So in stage 1, we did have that requirement. In stage 2, we introduced the notion of a specialty registry. So a state could create its own unique kind of registry that spoke to the scope of practice of their providers. So if a state wanted to build a new kind of registry, now they can use the 9010 federal support to build something that is helpful in coordinating care. So what a state could do, if so inclined, was build a registry that connected the EMS providers to the incentive eligible providers in hospitals. So you could imagine a couple of scenarios where this is helpful. So if you have an EMS provider who gets a patient and you need to check something on that patient, you can have a statewide registry where you look up some piece of information that's relevant. And I'm thinking of mental health, substance abuse here. I'm thinking of you need to find out if the patient is off his or her meds, or if there is, maybe it's even related to a PDMP, so a prescription drug management program, or maybe there's some sort of mental health, behavioral health registry that is relevant to see if there's some sort of intervention or care plan in place for a patient, or maybe it's about superutilizers, because some states are using some registries as sort of a superutilizer registry where they have all their high-cost sort of multiple chronic condition patients in one registry where they coordinate their care. And so maybe you query that when you encounter a patient. So there are a couple of models that could be very helpful here that if a state wanted to pursue, we'd be very receptive to pursuing some of those suggestions. So we're all ears. The states do have to want it, and they do have to come with the 10%. But the limits on the specialty registry are really more about what the state wants to do as opposed to what CMS wants to do. Like, states are getting really creative about these. So they're building homelessness registries, lead registries, Zika registries. So there's a lot of states there that are really using the registries to respond to their scope of practice and their statewide priorities, their public health priorities. So this is an opportunity to get sort of creative when you think about those specialty registries, and we're very encouraging of some innovation in that area. Next slide, please. And the interoperability standards, so this is tied to the Medicaid enterprise, so the statewide Medicaid system. So you should just know, if nothing else, if we at Medicaid stress interoperability, we stress the importance of reusability. So if we build something that EMS providers use, we want these roads that we build to be driven on over and over again for other programs. So if the state wants to do other sorts of ACOs, or innovation models around hospital readmission reductions or bundled payment initiatives. We want them to be reused. That's important to us. Leverage these things we're building. This is very, very important to us. So that's sort of your main takeaway there. Next slide, please. And yeah, just we're tying ONC standards to CMS standards more and more. So we believe this will encourage future interoperability even more so. Next slide, please. And this gets a little nitty-gritty. This will be important for if you pull in your state Medicaid agency. We'll go into all of this. So if you get to the point where if you reach out to your state Medicaid agency, we can give some assurances that it will be money well spent because it will be interoperable according to some existing federal mechanisms of ensuring interoperability. Next slide, please. So the state Medicaid agencies will need to ask this money. The money goes to the state Medicaid agency, and then they will use it to either build where they're going to build or onboard the EMS providers. So it doesn't go directly to the EMS providers. I mean, it kind of can. Like it's this material support for the EMS providers. So if you're onboarding an EMS provider, like that's going to be something, a material support, something they would have otherwise had to pay for. And then the architecture similarly, but it always has to originate at Medicaid, and the Medicaid has to, if they're going to partner with the EMS association or company or whatnot, they have to sign, contracts and memorandum of understanding, and those are reviewed by CMS, but there's really no reason they can't. Next slide, please. And this is all part of the efforts toward delivery system reform, right? So this is going to connect everything for making sure that the entire continuum of care is connected to make sure that Medicaid patients receive the best care because it's tracked from care setting to care setting. Next slide, please. I think we added some EMS special slides. We have some questions. So email me. If you can see that brilliant address, that'd be great. That would help me out because I've used them to help me track some of this. Your state Medicaid agency should have access to this website, Medicaid HITECH .org, if they have questions. So if you're trying to explain to them what the heck you're talking about, that'll help, or just have them email me. So your state Medicaid agency is somebody I probably already work with, and I work closely, detailed with the CMS Medicaid team, and we can connect you to them directly. Every state has a regional representative that we can sort of use to initiate a conversation. Next slide. So this is a good sort of takeaway. Read the letter, and do we have a link to the letter? I'm not sure.
Do you want me to talk about this, Tom?
Yeah, we could. Yeah, you want? Why don't you take this? Yeah, this is a good sort of step by step if you want to go through how to do this.
Great, thanks, Tom. So basically, folks, we kind of borrowed this, let's say, from some of our work we've been doing with public health about trying to outline some basic steps that you could take in regards to moving things forward. And I think, as Tom said, the biggest thing is talk to your Medicaid office, talk to your Medicaid office, talk to your Medicaid office. They're the key to this whole thing. The funding really goes directly to them. So you need to really partner with them and work with them very closely on this whole process. So in regards to step one, I would just make sure you understand and really read the letter that Tom and I list. In Tom's presentation, there's actually like a direct link that you can go to download a copy of the letter. But I think in that way, you'll understand it and be able to present your case well to your state Medicaid office. And if you have any questions pertaining to the letter, anything that you need clarification about, feel free to reach out to Tom and I, and we can definitely help answer those questions for you. So again, set up a meeting with your state Medicaid office, and I think too, is to also introduce yourselves if you are not familiar with them. Also, I think it's a good time to get a good understanding as to where EMS fits in your state plan in regards to health information technology and sharing data and things like that. There are, at each state level, there's some group that is providing guidance or direction to the state in regards to their health IT plan for the state. And so I really think that this is warrants a good opportunity for you all to get to the table, to talk with them, make friends, and hopefully so that they can also better understand where you all are coming from. Step 3, develop an interagency agreement between EMSA and Medicaid. You know, this is something that has worked with the public health folks and probably will work well in your cases as well. So your Medicaid office and public health, for example, are two separate agencies within the state, and it's probably very similar with EMS as well. And so often it's helpful to develop some sort of interagency agreement between Medicaid and the agency so that you're better able to, you know, connect around funding, to streamline some of the services, things like that, and to make the relationship function a little bit better. So that might be something to begin looking at. Step 4, drafting of, you know, the necessary documents. You know, Tom mentioned the IAPD. So become familiar with that, and again, talk with your Medicaid official to, you know, share the current example that's out there that they've completed, and I think EMS will, you all can provide relevant information that will need to be included in that document to move some of the projects forward. Step 5, 6, 7, I think it's a lot of back and forth. You're going to have to work closely with CMS. CMS is going to have to work closely with the Medicaid office and everyone to kind of come to some agreement, answer questions. There'll be a lot of back and forth until you are able to have some sort of resolution in regards to your actual project. So I think that there's definitely room to collaborate on this, and I think that this process kind of will make it really easy for you all to move it forward. And then lastly, there'll be, you know, a final approval letter from CMS that will come to the Medicaid office to say that they agree to begin moving forward in this direction. So next slide. So I know many of you are thinking, you know, what specific projects involve EMS that could potentially be funded, and Tom touched upon several of them, and I just thought I would highlight a couple here that I think are really relevant to you all in particular. One is the onboarding to an HIE organization, you know, to participate in the health information exchange. And this can be like unidirectional sharing of data in the sense like you just being able to view data. They don't have the capacity at this time for bidirectional, that's fine. Or it could be bidirectional, which is ultimately where we want to get to in regards to sharing data across the systems. The good thing is in the letter, the term health information exchange is loosely defined. So it doesn't just pertain to those state health information exchanges that were funded by ONC a few years ago, but we really see health information exchanges across the continuum now. There's private HIEs, there's also you know, integrated health delivery networks or health plans that have established kind of similar types of what we would deem as HIEs. You know, Tom used the term other interoperable systems. So I think it's important that you look within your communities and your states to see what actually is going on and to be able to utilize those systems that are already in place and to begin sharing information and data that way. Tom also talked about the web based care planning or encounter alerting for transitions of care. I think that this is really critical, particularly for those of you that have, like, say, mobile integrated health models of care in your states and communities. This would become a critical way to help with care coordination and things like that. So this might be a solution for that piece as well. And then it could be as simple as electronically sharing information, you know, just between the EPCR and the EHR in the hospital. You know, some communities and states don't have a very robust health information exchange network, so it's really making that point-to-point connection. And if that's the only type of service available, and in some cases it is, I think that, again, this might be also a possibility to look at it for you all. And then lastly, Tom also mentioned specialized registries, and I think this too is also a window for EMS to participate, particularly in accessing registries such as like Advanced Directive or POLST, P-O-L-S-T registries, PDMPs, of course, and even in some cases, you know, disease surveillance registries. This might be really a critical way to get connected in that way. And I know that there are a lot of states that are looking at developing all of these registries and looking at eventually connecting them in a way to share information across all of these registries. So next slide. So I also wanted to briefly touch upon some tools and resources that might help you all in this whole process and talking with your Medicaid office in particular. We have two tools, and they're outlined up top here, highlighted, and the links should be live once you get the slide deck. Both of these tools will be extremely valuable when you approach your Medicaid agency about the idea, if you to make the whole value proposition, the importance of HIE and EMS. I think that they'll give you some information to be able to share with them and to get their buy-in into this process. We also have two additional future tools and resources that will be coming out at the end of September. One is the EMS and HIE profiles of states and regional efforts that may provide some examples and ideas for your state or local EMS agency. I think those will be critical if you're really looking at integrating EMS into HIE. Again, the electronic POLST or advanced directive registries might be something your state would be interested in funding using these Medicaid funds as well. And this document will also provide a snapshot as to where some states and localities are in that area as well. And so lastly, I just wanted to also mention that Tom and I are here if you all have, you know, specific questions. You know, if your EMS agency would like to know a little bit more about whether or not this project would work, or you want to know who to connect to in your state Medicaid office, or if you want to also understand who your HIE is, whether it's a regional or state or community or private HIE, you know, we're happy to discuss with you and put you in contact with some folks in your state or region that can help you out. So with that, Noah, I think I'm turning it back over to you.
Thank you so much, Rachel and Tom, for all of that incredible information in a very short amount of time. This is an exciting but pretty complicated endeavor, and we've received over a dozen questions from folks on the phone. So we'd like to get to it pretty quickly. Real quick though, next slide, Kristen, please. I wanted to say that the ability to onboard EMS agencies into health information exchanges is probably the most feasible and exciting opportunity from this funding in my viewpoint. and it's already happening across the country. Right, and ONC is tracking a number of similar initiatives across the country right now, and they actually talk to each other every month, which is insane. And they learn from each other's experiences. We talked to that group earlier this month and just asked if anyone would be willing to put their name and contact information up here for this webinar, so that you can talk to colleagues in different states about who may be doing similar work, where they're struggling and where they're finding success. We really want to thank Dr. Peter Talak, who's the medical director for the Utah Bureau of EMS, and Dan Smiley, who's the chief deputy director at California EMSA, the EMS authority in California, for offering their email addresses publicly to answer any questions from folks from around the country who may be thinking about EMS and health information exchange. These folks are living it every single day, and they're incredible resources for you. So a lot of the questions that we've been receiving are about whether this is, when you say talk to your Medicaid office, right, and start to develop these plans and have these meetings. When we're talking about that, are we really talking about a local EMS service or fire department walking into their state Medicaid office, or are we talking about a state EMS official, a state EMS data manager, or a different state office walking into that Medicaid office? And so I wanted to pose to Tom and Rachel some questions about whether this needs to be coordinated by the state EMS office, or whether the EMS office certainly should be part of it, but whether there can be regional projects that can be funded, whether there can be more localized projects that can be funded through this opportunity, and where have you found success in the past in other health sectors?
So it's sort of all over the place. It's going to depend on the state. Some states, like they maybe are really standing up more of a statewide HIE, then it makes sense just for one group to sort of go knock on the door, state EMS. But some states might have more sort of fragmented, like you might have like a Texas or a Pennsylvania, where you have very major metropolitan areas, and the EMS vendors or participants this might just need to reach out separately. So another thing I wanted to throw out along those lines, and with regard to what Rachel said, which is we'll also introduce you. So if you're in a particular state and you're like, I'd like to do this, I want to get more information about it, I can introduce you to, virtually introduce you to the relevant Medicaid people in your state if you want, if we can help facilitate some of those conversations.
That's incredible. Thank you so much, Tom, right? Because I think I can think of several places in the country where regional health information exchanges are being developed, probably without the kind of buy-in and partnership with EMS that we'd like to see. And so the opportunity to connect the local EMS agencies in that area to the state Medicaid office and to the regional HIE is exactly what ONC is built for and what they're really, really good at. So that's an incredibly kind offer. We have a lot more questions, so we'll get right to a few of them while we still have a couple minutes left. Our second question is about use cases that you talked about, like query exchange and care plan exchange or alerting services. A question was, would those systems funded through this opportunity only work for Medicaid beneficiaries, or could they be used for all patient types and payer types?
So it's up to the state. Typically, they're going to build. Well, I guess there's no typical. So those systems could be statewide, or they could be Medicaid only. If they are statewide, they need to be cost allocated. So if it's 70% Medicaid in the system, you can use the 90/10 to support 70%. But I think one of the other follow-up questions was, what if it's like a hospital, a small hospital's use? Well, if you're doing a cost allocation, you're basing it on Medicaid providers. Probably all your hospitals are Medicaid hospitals, right? So you don't really have much of a cost allocation. Probably 95% of your hospitals Medicaid. So if you're building a statewide something for hospitals, then you have a very generous cost allocation. So it kind of depends on what you're building and what your denominator is in terms of your cost allocation. So this is one of those areas where it's good to talk to EMS so we can figure out the best way to go forward.
That's great. Thank you. The next question is actually about that 90/10 match. So this is an incredible opportunity, in part because the federal government is footing 90% of the bill, but that is still only 90%. The state or the project has to come up with the other 10% of matching funds. And there's a question about where in your experience has that other 10% come from in the past? Where have states found success in coming up with that 10%?
So with all the general funds, it's best to be general funds because we have to, if you go beyond, if you try to get exotic with the 10%, we have to review it pretty carefully to make sure there's no conflict of interest. So if you're the EMS group, you can't provide the 10%. You may think that makes sense, but it's a conflict of interest. And you can't match federal dollars with federal dollars. So it's going to be related to your one-on-one conversations with the states, but always shoot for general funds. Like that's the easiest way to go, and there's less sort of conflict there.
That makes a lot of sense. Excellent. This question can go to Rachel or Tom. And Rachel, you touched on this a little bit when we talk about statewide registries, right? So EMS data is being collected at a state level right now in nearly every state. And one of the purposes for that statewide EMS database is syndromic surveillance, which was listed in one of the slides in this presentation. And of course,
oh yeah, and that's fine. The syndromic surveillance is that's a hard yes. Yeah.
That's a hard. So that's awesome. So we have this thing called NEMSIS, and NEMSIS version 3 allows for near real-time collection of data from local providers. So EMS data is, in and of itself, a great opportunity for syndromic surveillance. One of the questions, though, is whether this funding can be used to develop and implement that type of syndromic surveillance. And then a caveat to that is, can it be used if it's sort of already going on? Right? So there was some question about existing statewide registries versus new statewide registries or linkages. Can you expand on that a little bit?
Yeah, so it's all tied to meaningful use. So as long as you're doing something that helps an incentive eligible provider meet the syndromic surveillance reporting requirements of meaningful use, it's inbound. So yes, that's fine.
Excellent. I hope all of our state partners who are listening heard that answer, because I think that's a really exciting opportunity. There was a question about a term you used, material support. And can you expand a little bit on what?
Yeah, and I probably shouldn't use that term. So basically, we can support the providers, we can support the systems, and it can be through contract or memorandum of understanding or whatever is sort of relevant. I mean, we don't pay vendors directly, we don't pay providers directly, but we build things that benefit them. So, and with that, I do have to go. My email is there. So it's been good talking to you, Noah and Rachel. Can you just make sure anybody gets any questions to me? And I would happily introduce you, anybody you need to introduce you to, facilitate any conversations, or just informally answer questions. So thanks a lot, everyone.
Thank you so much, Tom. I'm sorry, I should have mentioned to folks at the beginning that Tom had a hard stop right at the top of the hour. So we can't thank Tom and Rachel enough for their participation, their willingness to reach out to our stakeholders in EMS, and we're really happy that we were able to put this on today. There's a lot more questions that we received that were collected, we have, and that we will get answers to and post on ems.gov when we post the recording of this webinar in the next week or so. And so with that, that's going to conclude today's installment of EMS Focus. I again want to thank our presenters, Rachel, Abby, and Tom Novak from the Office of the National Coordinator, of course, for their continued and incredible partnership and their advocacy for EMS. This is real national federal advocacy for EMS that you're seeing live, and it's a really exciting time to be in the industry. Like I mentioned, today's webinar is being recorded and is going to be archived on ems.gov shortly. And for more information on our webinars, you can sign up for updates from the NHTSA Office of EMS by going to ems.gov and updates. We again thank you all so much for your participation. We hope you learned a lot and you take advantage of this opportunity. Please enjoy the rest of your day.